invade and metastasize the distant organ, only then we have the final development of malignant phenotype. How long do you believe this lasts? Just a guess. I prefer to make it more interactive because it would be much more challenging for you.
A few months.
5 to 20 years. So when you have a tumor, it's not a story that happens a few months ago. When you have a recurrence, yes. But the primary tumor, it's not a story of a few weeks or months. It's a process of years. So, as you can understand, carcinogenesis is something that it can be prevented, and I'm proudly said that as the ancient Greek Hippocrates said, it's better to prevent instead of treat. We could focus our interest after treatment on prevention. So screenings and diagnostics is what is required at that stage. Well, having all this on our mind, let's see how clinicians are working. Mainly medical oncologists. I'm not against them because I'm one of them, but we are doing a lot of mistakes on our algorithms. When a patient is diagnosed that he suffers from cancer, then the first step is we need to stage the patient. So you may have heard the oncologist said, we need to make a staging. Staging means how spread the disease is. Is it presented local? Is it presented widely on distant organ? Are they lymph nodes involved? Are they not? Is it a bone marrow infiltration from the tumor or not? So this is the immediate next step. And according to the histology report and the spread of the disease, we take the decision whether the disease is curable, whether we can get rid of the abnormal cells, whether we could surgically remove the tumor, whether we could apply radiation, or whether we could apply any kind of chemical medications or biological agents against the tumor. So we're talking about resection, radiotherapy, adjuvant chemo, or surgery, of course. Recently, we have the set of neoadjuvant approach. It means that when we see that the tumor is very difficult to be excised, but the disease is still local, we could apply therapy, radio or chemo, just to downstage the disease, so to shrink the tumor, and then make a surgery afterwards, and then apply again adjuvant therapy afterwards. So we have neoadjuvant, surgery, adjuvant. Unfortunately, many patients are stratified as non-curable. So in that stage, we send them to the palliative arm. So it's simply improving the overall survival and the quality of life. But let's see the happy end story here. That if the patient which is belonging to the treatable arm is reaching what is called remission, then we have to consider what is happening with this term, MRD. This has been borrowed from hematology malignancies, and it means minimal residual disease. It means that the disease is there, but we cannot diagnose with CT MRIs, and we need to know whether there is such kind of remaining disease cells, and whether the patient belongs to the high risk for relapsing of the disease or not. If the patient develops a recurrence, then we apply second line of recommended treatment. It sounds robust. It covers every aspect. Statistics came back and tell us, you're wrong. So we're not doing well. Something we are missing. So for the 5 types of major malignancies, 7.5% have an objective benefit. So something is wrong with our algorithm. First mistake. When we stage a patient, we send them for a CT, or MRI, or ultrasound, or cancer markers. It means that the limit of detection can detect no less than, let's take the optimal scenario of ½ centimeter of a tumor. Whatever it's smaller than that cannot be detected. So the disease is there, but we see nothing. And we say, there's no disease there. So imagine you have a primary tumor, and you say that there is no satellite tumors around, but actually they are. So immediately you start with the wrong staging. When we say curable, we consider only the extension and the histological type. We never consider that the disease is actually highly heterogenic. It doesn't behave the same to all its extension. The primary may behave differently compared to the metastatic one. Or even inside the primary tumor, you may have a proportion of the tumor that behaves with, let's say, with a very rapid growing rate. You have the periphery of the tumor, which has actually a slow growing. So, not so easy. Yeah, when we put all, let's say, an example, prostate carcinoma cases, hormone sensitive, which are in stage 2, hormonal therapy. Are you sure that all men are going to respond in anti-hormonal therapy? Of course not. All humans are not identical. We do not carry 100% the same genome. Why does your tumor have to behave in the same manner when it's an offspring of you? So actually we do not care that we have to deal with a single individual which unique features are carried on his body, and even more, unique features carried on his tumor. So we actually take the optimal condition that this individual belongs to the optimal center of the distribution of patients. We do not care whether it's belonging to the left or to the right side of the distribution, or even outside of the Gaussian distribution. Very egoistic, isn't it? From doctor's side, not from patient side. Downstaging. We consider that the tumor behaves, as I said, in the same manner in all its extension. So how you're going to shrink a tumor when this tumor is extremely rapidly growing? You simply cannot. You cannot. And simply you ignore the data that this tumor, either it can slow growing, which you may have a chance to downstaging it, or it's rapidly growing, what is called exponential phase of growth, which you don't have a chance to do. Not such an information is provided. Second line of therapy, I really dare you to go to both sides of the Atlantic, to NCCN and to ESMO, and find me to the majority of types of cancer that they do carry second or even third line of therapy. We do not have only this luxury for all types of cancer. So how are you going to treat a patient which comes with a recurrence and still he has a perfect body condition and you have no option? You send him to the palliative arm? Don't you think that this is ethical? As the Catholic priest would say, you will burn to hell. So, and of course we do not have so far parameters to stratify our patients whether they belong in solid tumors or high or low risk. So So as you can understand, the algorithm with first instance, it looks very, very precise, but be a little bit more careful. It's full of gaps. So this is exactly what we said with simple words. And this means that we need to apply personalized medicine. And thank God the last years everyone said, we have to do it. Hoorah! Let's see how personalized actually we are nowadays. Just to give you an example, if we want to apply specific options for treating epithelial kind of tumors, we need to block a specific receptor or a specific ligand which is called EGFR. We do a test to find whether a specific gene which encodes a specific protein called RAS, K or NRAS, is actually healthy, wild type, or mutated, so that we will select which of the medication is actually active. This is one option. But how many of these biomarkers are actually known? Extremely few, compared to the vast number and type of malignancies that we deal in clinical practice. So how we are going to apply personalized medicine with, let's say, biomarkers that you can count in the fingers of both hands, and simply you will have more fingers that you are not going to use them? Second, what we do as doctors is assumptions, which is really bad. Keep on your mind that doctors are not scientists. Scientists, they do carry mathematical and logical mindset. Doctors carry protocols. Two things that they are completely different. So a doctor in clinical practice has a specific mindset which based on assumptions. Let's give an example. In personalized medicine, we're talking about the cascades. That outside the cell there is always a signal which comes in, and then this signal triggers a kind of domino called signal transduction pathway. This is the term that you find in the literature. That at the end the signal concludes to the nucleus of the cell and gives a signal divide. So then, what is called targeted therapy, which belongs to the personalized approach, is actually trying to block something up here, either the receptor or the ligand. This is highly personalized as it introduced to us. And this is based on the linear signal from the membrane to the nucleus of the axis. But this is an assumption. What happens in reality? Can you please show me the linearity? So if you block something up here, always there is something else which may continue the signal. This is called cross-talking. So, not so personalized after all. This is the reason why the targeted therapy didn't give us these wanting and wishing extremely different some clinical outcomes. The overall survival is something which is really questionable now. And then, yeah, everyone is talking about genetics or doing sequencing, etc. But as you see, a malignant phenotype can be caused not only on mutations, but also on misfolding of proteins, which sequencing cannot give you any kind of information, or RNA abnormalities, which again, DNA sequencing will not give you such an answer. So just by introducing fancy technologies doesn't mean that you are actually doing the right work. So again, keep in mind, scientist means logical and mathematical mindset, which means that the scientist needs to introduce a specific technology when it's required and when it's necessary to be used. So when you do not have this mindset, it's really easy to be impressed by, let's say, very exotic technologies, which at the end may not be utilized. To make things worse, these things that we actually deal in clinical practice. When you give a drug, no matter from where these drugs come from, nature, chemical, monoclonal antibody, multi-TKI, checkpoint inhibitor, all the drugs, they need to go on a specific protein, bond with this protein, make an affinity relationship with it, stay there for milliseconds, and then dissociates. This is called rate on and rate off. If the affinity is weaker, it means that your drug is not going to work. If the affinity is sufficient but stays longer, it means toxicities. If its affinity is correct but stays shorter, it means that you are not going to see the biological effect of interest. So the drug is not going to do the work that you expect it to. And this has nothing to do with mutations, RNA, or proteins. It has to be done with microenvironment and the condition at that time of application. Parameters that you cannot control, and we actually ignore. So as you can understand, the level of analysis of a tumor cannot rely only on a DNA level. It needs to be done on multiple levels, on the gene expression, of the proteins, and also from the final form of the protein. So DNA sequencing or DNA analysis is only one of the required levels of analysis. The rest are actually missing. And of course, the treatment of cancer is not one-man show. You require laboratories, you require scientists, you require surgeons, you require medical oncologists, you require radiotherapists, you require supportive care which the patient needs to receive during and after therapy. And of course, the team which actually regulates the rest of the life of patients. What the patient needs, what the patient comes in contact with. How many clinicians do you actually know that they can sit on a table and actually exchange information? Because I know very few. Most of us, what we are actually doing is exactly this. Blah, 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 blah. We only talk, but we do not listen. Somehow we need to actually form what is recommended as multidisciplinary team. And this needs to be real, not in theory. Well, let's stop saying bad news and let's start seeing what options do we actually have. So, when you have a primary tumor, consider that 40 to 50% of all the cells are actually normal. This is the part of the tumor which is known as stroma. It consists from fibroblasts, tumor-infiltrating lymphocytes, normal cells that they actually interact with the tumor cells during growing and actually support the formation of the tumor from the structural point of view, but also from the blood supply. So you cannot obtain information of how the tumor is actually behaving from normal cells. And from the remaining 50% of the abnormal cells, imagine that only a tiny proportion, 0.000001, so 6 digits after 0% of the cells are able to invade, change their shape from flat egg, as we said, from the epithelial phenotype point of view, to round shape so that they will flow in the lymphatics and in the blood circulation. And these cells will migrate through the circulation to a distant organ and form the first microcolony. This tiny proportion of cells is actually the driving population. And since these cells are flow in the systemic circulation and is the actual cause of the disease, makes us to focus our interest in the liquid biopsies on circulating tumors. And not only us, all the scientists around the world. This is the reason why liquid biopsy becomes very, very important to us. Because it's practically impossible to find this tiny proportion of cells in commonly appeared cells in the primary tumor. And the second and more scary, this process of migration takes place really early. Already when the tumor is 0.2 millimeters in diameter, you already have dissemination. So this means 0.2 millimeters in diameter, which means that practically you cannot see the tumor. Already you have dissemination of microcolonies. So can someone tell me how we say that the disease is local when we already have microcolonies? So we have at the end, except the Fischer theory, which has been presented to us at the beginning of the 80s, on breast carcinoma, that cancer disease should be considered as systemic from day one. Simple as that. So we have to deal it as a systemic disease, not like local, excised, that's it, go home. So just to have an understanding, these are the methodologies that are used in clinical practice. So they can detect, in best case, this is an optimal scenario, a lump which may consist in 10 in the 9th cells. This is approximately half a centimeter. So you are talking about 1 billion of cells that you miss. Large number of cells per minute. So are we focusing on the wrong type of cancer? The answer is yes and no. We simply see something much, much bigger of what we actually should see at the end. Well, the heterogeneity makes cancer very difficult to us, because we do not deal with one entity at the in our clinical practice. So we deal with multiple subpopulations, and the more the disease is progressing, the more the heterogeneity becomes more plural. And we need to apply multi-level analysis if we want to achieve something in order to stratify our patients on responders and non-responders to specific therapeutic concepts. This is what is actually personalized medicine, not what we are doing so far. Well, CTCs. This is the entity that we need to focus our interest, simply because the larger proportion of them actually carries tumor-initiative properties. And these cells are called cancer stem cell lines. Well, and again, someone thinks we have the primary, cells are driving, are flowing in the circulation, goes to a distant organ and creates a metastasis. By far not true. The process is much more complex. From the primary tumor, we have dissemination of tumor cells. And these cells are actually, most of the time, they are going to organs which they can stay there without forming a metastasis. And these organs are called depositors. Such organs could be the bone marrow, the liver, the spleen, the cells will stay there, they will stay dormant. And they will receive the influence of several growth factors, which means that they prepare to become more aggressive, more resistant, and they start to interact with the normal cells. And together they reseed the circulation. For example, there are bone marrow derived monocytes and fibroblasts, which they migrate together with the disseminated tumor cells, and they form the primary niche, the primary microcolony. As you can understand, metastasis is a process which normal cells equally involved there. And imagine that we actually today miss the detection of this process. So all our clinical decision is taken without consider that there is dissemination and there are circulated tumor cells in a patient. And actually we may say that someone is cancer-free despite the fact that he or she may carry these cells. Well, and what is the relationship between the primary, the metastases, and the circulated tumor cells? From the genomic point of view, there are plenty of articles which proves that their DNA is practically almost identical. So mutation doesn't play much of a role there. But how it's possible? You have a metastasis and you have the primary, and when you treat your patient, you expect that since they have the same genetic material, they should behave the same. It's wrong again. Actually, you may have, let's say, a breast carcinoma case, which is hormone sensitive, which means that the disease is progressing due to the presence of estrogens. And then you have a metastasis in the brain or somewhere else, which actually doesn't behave like hormone sensitive. And both kind of cells, they have the same gene. How they are so different? The answer is that the gene expression is out. So actually the mechanism which regulates the expression of gene is different between the primary and the secondary. So the hormone receptor is expressed on the primary, and on the metastases has been switched off. So this makes the two entities behave completely different. But what is the relationship of the middleman, CTCs, is that it carries both entities' features. Primary and metastasis. Primary and metastasis. And this is from the epigenetic point of view and from the genomic point of view. So this makes them even more important, because if we want to treat a patient, we don't want to treat only the primary, but we want to treat as well as the possible secondary. The same. Well, hoorah! We conclude that we have to deal with the driving mechanism, with the driving cause of the circulated tumor cells. But how you're going to find them? That was the first challenge when we began our career. Because how you're going to find 10 to 30 cells per 50,000 events, per 50,000 white blood cells. This means if you multiply it with 5 times the 6 million RBCs, it means that you deal with 10 to 30 cells per 30 million cells. So you're looking at really a needle in a haystack. And not only that, you need to find them these cells, and have them pure, so you do not have any irrelevant cells at the end. Have them viable, have all the subsets of them, find which is the cancer stem cell like, and define them. So these are the criteria in order to do really a proper job. And here is a short video just to show you in a simplistic manner what are the approaches that exist so far. I'll do that. Okay. This is the positive selection. It means that we make the assumption that the cells appear the specific membrane antigen, but we actually miss those who doesn't carry it. Negative selection means that we take out all the unwanted cells, and then whatever remains are the CTCs. In older times we use the size isolation protocol, so we allow the cells to be selected with the assumption that the disseminated tumor cells are bigger than the blood cells. But actually, this is not true, so we miss the smaller cells. And also, we actually destroy the cells simply because we push them hard to pass from so small pores and holes. The microscopy-based method is really good, accurate, but you have to immobilize your cells. You need to kill them in order to stain them. The PCR-based method is a positive selection method. So you do not expect that all cells will appear the antigen, or that you assume that it should be there. So this makes more than obvious that negative selection is the best option so far. But it's not easy. You have to get rid of a really big number of cells. And you need to make it on multi-staging. Because let's say that you're going to do that in a mechanical way, you're going to destroy the cells as well. So choosing the right method is critical. For the time being, the only golden standard method of identifying circulating tumor cells is the cell search protocol, which is a positive selection method with the assumption that the cells carry an EpCAM antigen on the surface. But as you saw, you actually miss the cells that they don't carry. This is a typical microscopy-based method, fluorescent one, but all these cells are dead. You cannot culture them, you cannot analyze them further. This is a combination of gradient and beads, again with the same problems. PCR-based method, which at the end you conclude with DNA or RNA, so you don't have cells anymore to work with. And even though, that's to show you the rationale, because we shouldn't impress always by big words and impressive advertising. PCR is really a good method, it's really accurate. But in rare events, as are the CTCs, you have really a small amount of primary RNA to work with. So you have to pre-amplify it. You need to multiply it randomly. Immediately, this means that you are altering the expression rates from the laboratory perspective, from the real expression rate that exists in the patient. And this has been proven by experiments, which we did the PCR with amplification, with pre-amplification and without. And if the method was accurate, we should take the same fingerprinting. But we didn't. We actually alter the outcome. So it's a relative, it's really good and sensitive method, but not appropriate to use it for CTCs. That sounds very scientific, but what that means in clinical practice, we received samples from patients that they have been, let's say, took the label as cancer patients simply because they found circulating tumor cells on the periphery. Fine, but here it says that they found cytokeratins positive cells. It means that they use a positive selection method. Imagine, nothing is perfect in clinical practice. When you take a blood from a patient, you do have cells that they come from the inner lumen of the vessels, which are in epithelial as well. They are epithelial organ. So they carry the same antigen that also the malignant cells carry, cytokeratin. When we take out the endothelial cells, the same patient comes with 0 circulating tumor cells. Practically means that wrongly we put a label in the diagnosis of cancer to someone who didn't carry the disease. Can you understand how critical this is? Because if we decide to make a treatment decision, we're going to treat a healthy individual. It's at least unethical. Other technical issue. You take the cells, there are few of them. So somehow you need to make them more. If someone is familiar with, let's say, molecular biology or cell biology, they said that, okay, as long as you culture them, these cells have higher probability to change their phenotype and may not be identical of what actually are the cells inside the patient. Well, the experience has shown that you can grow the cells, but they can remain stable on growing phase from 7 to 9 days of growth. You can continue doing this after this period, but after the 9th day is that the cells start altering a lot. So you have a specific time window to multiply your cells and be identical with the primary cells inside the body. Is it sufficient this time of period to grow the cells and have enough material to work with? Well, again, the experience says yes. Simply because the cells, these kind of cells, are growing extremely fast. We compare it here with a known commercially available cancer cell line from pancreas of humans. And these are cells coming from pancreatic carcinoma, SCD6. The difference of growing rate is up to 10,000 times faster. In reality, it means that the cells are divided in every 20 to 30 minutes. To make it more real, let's say that you start with 100 cells, 1,000, 100, and you calculate them in 24 hours. In 20 minutes, if you run the maths, you're going to conclude with 1.6 billion cells. The number is huge. So you have plenty of cells to work with. And you are only on the 24 hours. At that time, we consider that this is only a random event, but actually we prove the concept that these cells are growing in the same pattern from all types of solid tumors. So actually we use that to multiply the cells and make our job more safe. And this is what is the outcome of assessing the old protocols to identify the cells in circulation. As you can see, all of the techniques, they have pros and cons. And this is really, let's say, ideal experiments. Recently, we include in the field of liquid biopsy the circulated free DNA. Someone may say, okay, this is much easier because we found the DNA of the tumor in the serum, and then we could analyze it. Keep in mind that this approach includes fragments, small pieces of tumor DNA that exist in the circulation. So you do not have the whole genome. That's the first. And the second is that the only thing that you can do is that you can identify this tumor origin DNA when your tumor carries a specific mutation. If it doesn't, you cannot be able to identify this circulating DNA. And the only utility of it is to find the extension of the disease. So the more tumor cells you have, the more free tumor origin DNA you are going to have. So you're not going to find any diagnostic or prognostic value of it. So here are the pros and cons of both techniques. So as you can see, CTCs can give you an early diagnosis, tumor progression according to stages. Drug tests, sensitivity tests, can give you analysis on multi-levels, on protein, RNA, genomic level, which, the free DNA can give you only information about the grade and the stage. That's it. No more than that. So it is a tool that it can be used only for this purpose, nothing further. So again, a very fancy method, but from the utility practical point of view, there are always limitations. But yeah, which method, which test? The answer is search. The answers exist out there. All the tests have been assessed. All the assays have been assessed. So here is the name of the test. I take out the commercial name of it. But actually it's the assessment of methodology, which says that it gives you from 100 to 1,000 times more the number of circulating tumor cells that actually exists. So it's not an accurate method to use it. So the more you read, the more clear understanding you develop of which method is more close to reality. And what I said is already written. Here. Cell search is considered as a golden standard, but it's already known that EpCAM doesn't express in all cancer cells. This is the reason why sensitivity and specificity is so poor. Despite the fact that it's FDA approved, this is something that everyone, oh, is it FDA approved? So what? This doesn't mean that it's credible. Credibility defined by scientific parameters. Specificity, sensitivity, negative and positive predicted value. All the rest are public relations. Yes, it is. Again, this shows the difference of 4 different techniques: cytogenetics, real-time PCR, flow cytometry, and next-generation sequencing. Here you can see the sensitivity of them. So flow cytometry can reach up to 1 to a million or up to 1 to 10 million actually. And real-time PCR can conclude to 1 to 100,000. If you're interested, I can give you these slides. It's not intellectual property. So no worries, you can take pieces of it. So obviously microfluidics and flow cytometric techniques are the optimal. For the time being, if we have further scientific development, we're gladly going to involve it. But for the time being, the methods to find and isolate the cells are the microfluidics. This is the reason why we're proposing these kind of assays, because we simply test them all. Well, returning back to circulating tumor cells and mainly to the driving mechanism, it's called cancer stem cell life. Keep in mind, this is really a tricky term. We use the term stem cells not because they derive from stem cells, but simply they behave like them. Stem cells are actually divide differently of what we know so far. They have the self-renewal abilities and the asymmetric mitosis. In the same manner, the tumor is growing. But there are also differences. The differences are that the tumor cells can go backwards in differentiation. This is how the tumor is actually progressing. It can develop stemless properties if the microenvironment allows it. And they are important because simply they carry all the necessary information. How to become resistant, how to avoid the efficacy of a therapy. And so far as you can realize, we treat only the proliferative cells. We do not treat the actual cause of the disease. So we need new agents. This is where the diagnostic becomes very, very important. We need to broaden our diagnostic processes. And in that effort, we have developed, based on the previous technique, this kind of tests. The OncoCount trace and trails, which simply enumerates phenotype and circulated tumor cells. The OncoCount gives only the number of circulating tumor cells in the presence of stemness. But the OncoTrace, which is much more comprehensive, can give you information about not only the number, but whether you have stemness in the cells, the origin, markers which are related with the risk of relapse, etc. And simply because there are specific, as we said, 5 types of cancers that they are actually covering 70% of all malignancies, we took a subset of these biomarkers and we created the OncoTrace for prostate, for breast, for lung, which simply you can distinguish whether it's a squamous cell, so different histological types, and sarcomas as well. And this test can be used for following up a patient. By the number and by the phenotype, you can find out much earlier when a patient is belonging to a high risk after treatment of developing a recurrence. So you don't have to expect to see the recurrence so that you will take measures. But before following up a patient, you need to treat him. How are you going to do that? This is what the Onconomics platform is used for. But here we use the golden rule. We use the gene expression profile and the viability. So you have 2 approaches at the same time, which increase the efficacy of the test. What you could see are the validated biomarkers, which are pretty much plenty, but they are involved with these functions. Either they regulate the cell cycle, how fast the tumor is growing, how resistant it could be, whether you have new vessels formed in order to grow and metastasize, and whether these tumor are going to respond on physical interventions. Keep in mind, the tumor is not only excised or be exposed on radiation or chemotherapy. Equally, a tumor can respond to microwaves, ablation, hyperthermia. So it's not only 1, 2, 3. The options are much more wide. And of course, the viability test will show you the efficacy of the active form of a drug after we expose the cells to the lethal concentration of 90%. And the outcome is presented to the clinicians in a manner that they will understand it. We don't want them to become molecular biologists. It needs to be scientifically based, but easy to read and understand. Of course, to that field there are the natural and biological products. So someone may say, oh, biologicals and natural products. Well, if you're working in a drug development, anyone would know in that field that 80% of the drugs that we actually use in our clinical practice are derivatives from natural products. One of the major strategies of drug development is what is called ligand-based drug design, which simply means I take a natural product and I shift the form so that it will work like a drug and I make a patent of it. typical example in oncology are the taxanes. Taxanes are actually extract from the edge of leaves of a tree. Etoposide, the same. So most of the medications that we use so far are derivatives from natural liquids. So far there is no de novo drug outside. Just to prove the concept, these are the new generation of targeted therapy. Imatinib, mesylate, sunitinib, sorafenib, and sirolimus. See the structures? Here, here. See the natural products? Here, here. See also the nucleotides. Here, 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 here. All of them are derivatives from quinazolines and derivatives from penicillin. These rings are really, really medicinal products, simply because they fit to the ATP cassette. Most of the proteins, they catalyze ATP, and ATP has this structure which is really perfect there. So it's not a rocket science after all, don't you think? Simply the difference is that natural products rapidly degrade. This is the problem. That's why you need to apply large amounts and more frequent than the typical medications in order to achieve the same biological effect. That's why we try to change the structure to increase the lifespan of the molecule inside the body. This is the only difference. So the other differentiations is simply a marketing reasons, or I don't know, you cannot find any other rational way to explain it. Well, as drug industry does, we assess this natural product according to their function. So either they will have a direct cytotoxic effect, or they block growth signals, or they interact with the immune system and the rest of the cells so that they will induce cell death. This is how natural products and most of the medication actually work. And they present it by the percentage of efficacy, so that quickly someone will classify them according to their functionality. How they should be used? Yeah. The Onconomics platform for identify the treatment option, and the OncoCount and Trace for following up the patient. But recently we have the immune therapy as an option as well. But in order to apply an immune therapy, you need to be sure that the patient has the proper immunological conditions to receive it. You cannot treat a patient who is immunocompromised or suffers from cachexia. So, immune therapy can give you really a profiling whether a patient suffers from immunosuppression due to Tregs or cachexin, and whether it has antigen-presenting cells and category of cells that they can produce antibodies, or they may have direct cytotoxic effects. Of course, I will make it a little bit fast here, because what you are mainly interested is not only to treat a patient, but also to identify whether your patient is capable to activate your drugs. Your medications that you give to, the medications that we give to our patients are not active 90% as they are. They need to metabolize inside our body so that they will take their active course. As long as we ignore that, we consider that all human beings are optimal metabolizers. This doesn't exist in nature. So the ChemoSNP will show to the clinicians whether someone is actually a normal metabolizer, which is what you want, a rapid metabolizer, which you don't want. Means that it activates the drugs and eliminates very fast, so you cannot achieve therapeutic concentration inside the body. Or an accumulator, which is even worse. It accumulates byproducts inside the body without the ability to excrete them efficiently. So it means toxicity. You may actually kill a patient instead of treating him. Just to give you an example. In In colorectal carcinoma, one of the drugs that is used as a second recommended line is irinotecan, counterfeiting derivative. If you expose the cells to irinotecan, they will do nothing. This drug needs to pass on the liver and receive two reactions, two removal of carboxylated groups, and then becomes a product known as SN38. This is the active form of the drug. If your patient cannot metabolize it, the drug is not going to work. And on the other hand, if it cannot excrete this SN38, you are going to kill the patient from side effects. Have you ever seen such a case? Actually, the patient suffers from massive diarrhea, loses in few hours all the fluids and electrolytes, dies from arrhythmia and heart stop. That's it. And don't consider that this is a rarity. Happens. One. So, treatment algorithm. You cannot treat someone who's not able from the performance condition. From the performance perspective. We treat it. So we classify the patients to good performance according to Likert scale and to poor performance. So the treatable arm is only the good performance, which then we have to do an actual staging of the disease. How extensive the disease is with a low limit of detection. If the patient is in an advanced stage, if it's in the remission, it's in the minimal residual disease, don't try to treat these patients with conventional, at least, chemotherapy agents. The toxicities are much higher than the clinical benefit. So try to have a different approach, immunotherapy or cellular therapy. But in advanced stage of disease, in order to make a decision, the economics will give that information, and the SNP test will tell us whether the patient is capable to metabolize the drugs, and then we are able to create a product. And in order to follow them up, trails and trace can be used. What about the poor performance patients? Instead of leave them as they are, you can do a biological agent therapy simply because the toxicities of this product is much more mild and they are easily tolerable for these patients. Hopefully that their performance will be improved and jump to the treatment arm. So what we try to show here is that you don't need only the pharmacodynamic, but you need the pharmacokinetics as well. So far, this doesn't exist. We ignore it. It doesn't exist in clinical practice. Ever. So then from the options that are provided from economics, you take out all the unwanted metabolizers from the SNP test, and the options that remain are the options that we should pick up for selecting a treatment. Usually when we treat the patient, first we need to synchronize the cell, and then kill them. So first, cell cycle dependent inhibitors, and the second option, non-cell cycle inhibitors. Few tips. This is mainly for clinicians. You need to know how rapidly your tumor is growing, or how capable it is to respond on physical interventions. So these are the biomarkers that they can easily show us this information. What are the clinical outcomes? These are actually feedback from clinicians, which even on multi-treated late-stage patients, we manage to generate clinical benefit. Breast and prostate and colorectal carcinoma. Of course, someone may say, okay, these are assays which are what? Are they stable? Are they accredited? Of course they are. They are according to the International Standard of Characterization of Prototypes of P025, which from the certainty parameter assessed, they are accurate 0.04% of certainty. So they are extremely sensitive. But how clinical relevant they are, they have been assessed on June 2015. These are the parameters for all tests around the world, not the FDA approved. Okay? So as you can see, compared to the golden standard, we are by far better of what is considered as the best option. As you can understand, I'm only the speaker. This is a teamwork. This is a part of our team. Thank you for your time. Any questions that you may have, please answer.
How long does it usually take for example, once a patient is diagnosed and their sample is sent to a lab? How long does it usually take for an algorithm to be
for a treatment algorithm to be developed for them?
Well,